Yeah, why don't we go ahead and get started? I think webinars now seem to turn into podcasts a little bit. People just people catch them on the replay, which is fine. Although I was hoping to get some lively discussion today because it's a big topic. So, welcome everyone online and on replay to Moberg Analytics case studies in Neurocritical Care AI webinar series. Thanks very much for joining. Uh, I just want to go over a few things before we get kicked off today. The reason we're doing the reason we do these webinar series is the reason we do a lot of different kind of things that are outside of the realm of creating products, and that this is a big mission that we're all on, understanding and treating brain injury, and our goal is to help, in whatever way we can on that along that mission. So we're doing these webinars. We've got resources online at neuromonitoring.com with different lots of different resources that we hope you will check out. We also are doing starter grants and low cost pilots to get people going on applying these AI and advanced analytics techniques to their data. So you can reach out to any of us at the company for things like that. Also, if you have any feedback, please use the QR code or either one of those links or my email address to give us some feedback or to volunteer to speak. We know there's just tons of stuff, really cool stuff being done out there, and we would love to get people out and give them a vehicle to share some of the work that you're doing. There's a huge list of replays that are going on. I think we've got about 20 or 21 of them out there now. So make sure that you go back and catch up on some of these. As I said, this is one of the resources that's on the neuromonitoring.com website. If you go to that one /webinars, you can see all of the replays going back to a couple of years now. If you have questions, please use the QA. We all know how to do that by now. Also, this year at the Neurocritical Care annual meeting, we're going to be doing the second time we've run this workshop. We're doing an informatics, big data, and AI workshop on Tuesday, October 20th, ahead of that meeting. It was a wonderful event last year. We had a lot of great feedback, and it was really great. A lot of great presentations. We're going to talk about data harmonization, data formats, data cleaning, compliance. And go through a few specialized algorithms that we have, like autoregulation and how to do, visualization modeling. So if you want a hands-on introduction into what it's like to work with neurocritical care data, do advanced analytics, sign up for that. The workshop. Today, we are really super happy to have our longtime friend. He's probably well known to most of you. He will need no introduction, but I'm going to give him one anyway. Dr. Claude Hemphill. He is professor of neurology and neurosurgery at the University of California, San Francisco. He's also chief of neurology and director of neurocritical care at Zuckerberg, San Francisco General. There. He's the founding director of the Neurocritical Care Society. So way back when, he was one of the first people to decide that organization needed to exist, and he's the founding director of that. He's also on the editorial board of Neurocritical Care, Annals of Neurology, Neurological Research and Practice. He's in a number of writing groups. He's just quite a presence in the field. He's the current co-chair of the Neurocritical Care Research Network and the leader of the Curing Coma Campaign. Today, he is going to talk to us. We saw a paper that he and Dr. Garrett Myfroy published a while back about the possibilities, liabilities, and concerns, confessions of an AI skeptic. So he's been working in this field for a long time, and he's going to share his perspectives on the implementation of AI in neurocritical care and beyond. And I would like to make a special request, really, to turn this into a dialogue as much as possible. We really want to hear everyone's views on this topic. What has been successful in your organizations with regard to AI? What has not? How are your organizations treating it? Are they creating on-ramps to help you implement it, or are they creating roadblocks that make it hard? I've been a technologist for about 40 years now, and I really believe we are at a unique place to have this technology with so much potential and so much power that and it's nobody is going to figure this out. Government's not going to figure it out. It's going to be up to the people, the clinicians at the bedside, working with technology companies to get it right. And we must get it right. And we'll do this, through dialogue and openness and debate. And we're going to really have to work together because there isn't an overarching body that's going to help us implement AI in a thoughtful and safe and advanced way. I know I had, an interesting post the other day on LinkedIn, where if you know Eric Rosenthal, one of the leading clinicians at Mass General, he left that position and accepted a position as um, the director of digital and AI for Mass General Neuroscience Institute. So this is an indication of how important this topic is, where Eric's making a career change to apply these techniques. So I think you need no other evidence that this is an important topic. So anyway, I will stop yammering on because Claude's on a limited time thing, and I will turn it over to him.
Craig, that was a exceptionally generous introduction, and I really appreciate the opportunity to be here today. You know, it does some feel like I'm a bit of a gray beard now. I have gray in my beard, and when I think about working with you and Dick for decades, and Ethan as well, and appreciating that perspective. And I agree, it feels that we are at a inflection point. So I'm going to, let's see, I need to get my sharing turned on. So I'm going to bring up some slides, and let's see. Feel like I'm taking us a little bit into like a Monty Python skit, um, compared to the topics and formats of the many of the prior AI webinars that you've hosted. I say, and now for something completely different. I'm going to start off talking about natural intelligence, because natural intelligence is this innate cognitive abilities, emotional understanding, adaptability of living organisms, acquired dynamically through lived experience, social interactions, cultural immersions, and trial and error. It possesses consciousness, common sense, empathy, moral judgment, excels at creative thinking, intuition, applying abstract reasoning to new and unseen situations. And that really is what we've been used to. That's the development of natural intelligence. And if you look at the paper, you would say, I'm an expert. I have loads of NI. I've had formal training in neurology, critical care medicine, neurocritical care. I'm a professor at a university. I have 30 years of clinical experience making and implementing medical decisions, but also in that context, counseling and working with patients and families about very serious things that relate to medicine, but also relate to ethics and values about life and death. Got board certification in several different specialties, a couple hundred publications, right on the numerous guidelines. And I have come to the realization that I am probably about as good as I'm going to get. I'm probably not going to get much better, and that I need help because of that. So it is important to think about the limits of expertise. Clint Eastwood reminded us of this more than 50 years ago. A man's got to know his limitations. I think the same thing applies for women. And then it's interesting. There's this quote from Donald Rumsfeld, who was the defense secretary roughly 25 years ago, that has been repeated a lot, that almost in sort of a joking manner, but it's interesting because there are known knowns. There are things we know in it. There are also known unknowns, to say there are things that we know that we do not know, and then there are unknown unknowns, the ones that we don't know, we don't know. And that's actually pretty pretty right on, because much of what we hope we are going to do is at least take the known unknowns and move them to known knowns. And that's kind of what Hounsfield did when he described in his Nobel Prize speech about conventional methods of X-rays were not making full use of all of the information that they could give. And that's how he developed a CT scan. And I think a true expert knows what they don't know. So why do I need help? I need help because of data, and more data. And this data comes in a lot of different formats if we really step back and think, what is data? I oftentimes in my day-to-day rounding in the neuro ICU think about data as patient monitoring data, like physiology data, the blood pressure, the intracranial pressure, or electrophysiology, the waveforms that I'm seeing on EEG. Imaging is obviously data. Serial neuroexams. Really, there's group level data. The medical literature is just expanding and expanding with clinical trial results and guidelines and cohort studies and mechanistic studies. And this is data that I have access to, but it doesn't, I don't have, I need some way to synthesize this and bring it together so that I can utilize it. Otherwise, I don't even know it's there. But then experiential data, my own experience or experience of experts and colleagues. And in clinical medicine, that's a very, very important and powerful set of data. What we learn when we're rounding together, what we learn when we see our patients, what we learn from our mentors, colleagues, what I learned from my trainees and my bedside nurses in the context of these patient care encounters. And a lot of that's not written down in the medical literature. It is experiential, is what we learn from being together and going through these activities and developing natural intelligence. But if I want to go to an archive to find that, to use that, doesn't exist. So now let's talk about AI, because AI, we're going to define it as simulation of human cognitive processes by machines, utilizing algorithms and so forth. Learns computationally through large data sets, which means there has to be a data set to learn from, pattern recognition and feedback loops, and excels at vast amounts of information, repetitive tasks, and it doesn't fatigue, at least not like humans do. And I do not do the coding. I do not do the deep machine learning analytics. But for some reason, I've been asked to write several editorials and book chapters on AI and neurocritical care. And I am assuming that it's because I at least have opinions about the clinical landscape and implementation. So I'm going to give you some of those opinions developed through experience and maybe NI development. Because what I'm really trying to understand is how can artificial intelligence augment my NI, or maybe make it, maybe AI is augmented intelligence. So how can AI help? I mean, we've talked about this in a lot of these case series, but obviously in other contexts, and diagnostic tests with complex data such as electrophysiology or imaging. Very, very obvious and tangible examples of where this could be really, really powerful, and it's really becoming more and more so. Synthesizing real-time ICU physiology, trying to think about integrating multimodal neuromonitoring, obviously a big priority of Moberg. Finding existing facts, okay, that's really important. Getting into that medical literature and other aspects that exist there that I need to access. And then how about making decisions about medical treatment? This is something that, is certainly, I would say, controversial now, but there's a lot of interest in this potentially as well. So let's start with some of those first use cases, and we think about, here's example of an EEG, and there's a visual pattern recognition that over experience, experts learn how to interpret this, but it's kind of challenging. I mean, when I when I show this to folks at the bedside who don't have a lot of EEG experience, they don't even know where to start. It's not obviously intuitive. And in fact, I'm not an electrophysiology expert in that I'm not trained to read EEGs independently and so forth. I've gathered the information by working in a neuro ICU and working with my colleagues who have more expertise. And so we actually had our grand rounds in neurology at UCSF last week, given by John Kleen, who is an EEG electrophysiology expert, and Eddie Amram, who is a neurointensivist, works with me, especially at San Francisco General Hospital. And they talked about some of these opportunities, and I appreciate John and Eddie letting me borrow a couple of their slides. I think that one of the intriguing ideas is making EEG interpretation, let's say, more straightforward and accessible to non-experts, as well as helping experts with the large volume of data in order to identify, maybe sort of remove things that are normal and focus on things that are really abnormal that would be targets for intervention or study. And so paper, I think 3 years ago now, that looked at automated interpretation of clinical EEGs using AI and found it was quite good, at least at classifying normal or abnormal, what are the epileptiform activities, and so forth. Now, this algorithm did not tell me whether I should order an EEG or not. It did not tell me whether what I should do with the information in terms of treatment. It was strictly limited to interpreting that data in a way that was, let's say, challenging or laborious. So, but moving forward to some of these, let's say, known unknowns, John is doing a lot of work with Eddie Chang, who is the chairman of neurosurgery at UCSF, and Krunish Ganguly, who is a neurologist who's chief of our neurology division at the VA, working on things like a brain-computer interface and so forth. And that's absolutely a necessary. We're not going to get this through NI. We're going to get this through AI, and that's a very, very powerful translation of something for a tangible treatment. So the other area, we talk about neuroimaging. So, here's a patient that I was taking care of about a week or so ago. 69-year-old man, right hemiparesis aphasia. He gets a non-contrast CT scan. And I look at it and I see there's some hypodensity on the left side, and he's got a left middle cerebral artery clinical syndrome. And even now, we use something that many folks are using in their clinical context. We use this imaging software called Rapid AI. There's another one called Viz AI. I think they put AI in there because it sounds cool, but these are the push notifications that go to an app that I use. And what they do is, on the left, they calculate the aspect score, which is it's an automated calculation of something that didn't used to be automated, but it's looking at areas of hypodensity. And it's detecting whether it thinks there's an LVO, large vessel occlusion, and looking at the perfusion imaging and doing a calculation about whether it thinks that there is a perfusion deficit and whether there may be tissue at risk that's potentially salvageable. This is actually not that complex. It's not really fancy machine learning, but they call it AI. But it is automated analysis of brain parenchyma vessels, perfusion, and push notification. So this really interesting synergy between, quote, AI analysis of data from imaging and workflow optimization, which is also very, very helpful and potentially powerful. But there's been more work, and I think we know that the idea of imaging for detection of lesions and measurement of lesions and more advanced assessment is really an area of great interest for AI. Here's an example of a deep learning algorithm for detecting intracranial hemorrhage which is something that we are often looking for on CT scan. Now, I think I'm pretty good at detecting intracranial hemorrhage on my own, but obviously this is something that could be powerful to export. And then one of the things that has been a really, really important new, I'd say maybe it's not really a new concept, but it's a expanded recognition and new attention to a concept that we've known has been there for quite a while, and that is covert consciousness, or also cognitive motor dissociation. Patients that are not able to respond with a motor output when we ask them to do something on neurologic examination. But in fact, if we do a functional MRI or advanced machine learning EEG, their brain is actually responding. And those patients are much more likely to have improvement and recovery than those that are not, but also this could potentially be targets for intervention. But this is not something that we're going to be detecting on our standard routine CT and MRI scans. It's going to absolutely require advanced understanding of the imaging, but also advanced analytics in order to create a pipeline to bring this to the bedside. So those are really tangible examples with electrophysiology and imaging that we're doing now and that are being pushed forward. Let's go do some rounds. Let's go to the bedside. And so this is my paper chart back before electronic medical records. And I call this paper chart actually a data visualization tool because I had a method where I would go to the bedside and I would actually start in the upper left-hand corner and I would do clockwise around, and then I would get to about 9 o'clock and then I would go in, and I had this pattern of how I would analyze this. I thought I was pretty good at looking at it. I could use the information in real time at the patient's bedside. Of course, I couldn't go back to my office and look at it. I couldn't look at yesterday or the day before without having to find the chart from that day. So we got electronic medical records, and lo and behold, this is kind of what we have. And the problem is most ICU electronic medical record charting system just kind of look like the old paper chart, but in electronic form. So this is very useful for archiving, but these really didn't give us much of a substantive advance in analysis. So I think the computer science perspective is very interesting, and a colleague, some of you may be aware of really a leader in the AI field, Stuart Russell. He's a professor of computer science at UC Berkeley. He's been working in this area for over 30 years, and he did some of the work that was very important on speech recognition and a number of different development applications of AI. And a number of years ago, Jeff Manley, who's a good friend and colleague and chief of neurosurgery at San Francisco General Hospital, and I would say maybe the world leader in TBI, we were working together through some work that Jeff had with a grant working with Intel and Stuart from computer science at Berkeley on some early neurocritical care informatics work. And I'm going to tell you about that in just a moment, but or at least Stuart's perspective. But his current concerns actually include the threat of autonomous weapons and the long-term future of AI in its relation to humanity. And I think that's pretty interesting that this is where one of the early leaders in the field has now gone as he has become more senior. And I would encourage you to read this book, Human Compatible AI and the Problem of Control. It's a good read. It's very, very interesting, and I think Stuart has that longitudinal perspective that we would do well to consider. And he rounded with us for several days in the neurocritical care unit at San Francisco General. Afterwards, he said, Jeff and Claude, you guys are practicing dynamic Bayesian network state transition theory when you manage your patients. And I said, yeah, whatever. I don't think so. I mean, what I really do is I know what my patient looked like yesterday, and I know how many similar patients have done previously based on my experience, and I know the medical literature pretty well. And so I look at the patient on rounds and this large amount of physiology and neuroimaging text-based data from numerous sources, monitors, scans, notes. And I got to decide what to keep and what to ignore and decide how likely my patient is going to get sicker over the coming hours of days, because then I need to perform new diagnostic tests or implement interventions in an attempt to avert that deterioration and limit ongoing brain injury. Exactly. That's exactly what we're doing. We're doing dynamic Bayesian network state transition theory. And this means that this is something that could lend itself potentially to thinking about the process and workflow of how decisions are made in order to bring AI on top of NI. So this is the IC monitor we have. Very nice colors. We've got green and blue and red and white and gray, but it's really just numbers. It's numbers in real time. And what we really want is this sense of data integration. The value of that data really depends on how we integrate it and the decisions we make. The things that I'm doing, we're doing when we're on rounds where we take that information. So wouldn't it be great to have a monitor that does analytics and risk state and phenotyping and so forth? And there is increasing attention, and Moberg is helping lead us in this. But the idea of bringing this information together in a way that can enhance this and I'd say not mimic our processes, but enhance our processes. Just, one example of machine learning to predict the future development of intracranial hypertension, but there are a lot of interesting examples here. But I'm going to move us on from this data because I go back to my own clinical experience, and so I'm rounded in the neuro ICU. And, I have a team of fellows, residents, and students. People have a lot of different levels of NI. They've got a lot of different levels of experience. They want to learn. They want to get better. And one day we were joined by one of the early pioneers in quantitative pupillometry, Dr. Merlin Larson. Merlin is an emeritus professor of anesthesia at UCSF, and he was using the pupillometer many, many years ago and has thought a lot about not only the clinical application of it, but the science underpinning the values that we get derived from pupillometry. So we're doing like we do every day on rounds and seeing several complex patients with coma from neurologic injuries. And a question arose regarding different reflexes that may or may not be present and whether we could do brain death testing if they were. And particularly Merlin brought up the ciliospinal reflex. And the trainees did not know the answer to his question. So we thought it would actually be kind of fun to ask ChatGPT. Said, okay, let's do that. That's what maybe trainees will ask their mentors, they'll ask their professor on rounds, but they can really easily just go to ChatGPT on their phones and so forth and ask a question. So the ciliospinal reflex, just a little bit of neuroanatomy, it happens where the pupil dilates after a painful stimulus, such as pinching. Could be to the neck, upper trunk, or face. It's been described, 170 years ago. And various anatomic studies describe it as outside the neuraxis in the thoracic sympathetic nervous system chain only, or actually transiting through the medulla and midbrain and involving the sympathetics up to the hypothalamus. And this is important because if brainstem function is preserved in any fashion, then a patient would not meet brain death criteria. So here's what I plugged in. I just plugged into ChatGPT, just said, is the ciliospinal reflex present in brain death? And it said yes. Patients who are brain dead can still have the ciliospinal reflex and how it's mediated. Okay, well, thank you very much. But we had our pupillometry expert there, and I obviously knew as well that there were multiple different possible pathways for the ciliospinal reflex. So I put back in, I just said, I corrected. I said, that is wrong. the ciliospinal reflex is not present in brain death. And ChatGPT responded, "You're correct. I appreciate your patience." And so thank you for pointing out the error. They are very courteous and so forth. And I thought this was really interesting and kind of disturbing because it's a conversation that's going on there as opposed to looking up the brain death guidelines, looking up the anatomy of the reflex and trying to understand how that could be determined. So if a trainee put this question in and stopped there, or a junior physician or senior physician, without looking at more of the primary literature and stopped at this first response, that would be very problematic. So it really got me thinking, what does AI mean to most clinicians? Fact is, most treating clinicians are going to be utilizing AI and exposed to AI, but they're not doing the advanced coding to assess predictive modeling of advanced physiology. They may not even be thinking in a detailed way, although they should, about explainability and the data sets from which the information derived when we're even thinking about the EEG and imaging data. But most clinicians are going to engage AI through two main portals. One is AI scribes to summarize narrative data in the electronic medical record, things like progress notes and patient visits and hospital discharge summaries. And these are being used now, and they're being expanded and encouraged, actually. And then generative AI through large language models, where someone looks up on their own and uses the information themselves, really at their own discretion. And this is happening a lot. I was at a neurocritical care summer school last week in Monza, Italy. Giuseppe Soterio, who's a real world leader in neurocritical care, has had the summer school now for 9 years, and he brings in fellows and junior faculty and a number of international faculty who just discuss various aspects of neurocritical care for a teaching format. And during some of the talks that I wasn't giving, I was sitting in the back doing some work. And it was really interesting to see how many of the attendees had their laptops open and had Anthropic's Claude, not me, the Anthropic's Claude open, ChatGPT, or Open Evidence. And as they were listening to the lectures given by their, us and our NI experts, they were typing stuff in. And so these are used a lot. And what does an LLM interface look like to a clinician? Well, it's fundamentally different than a search engine that returns links to primary source data. I think that we are used to for a long time looking up and saying something about intracerebral hemorrhage, hematoma evacuation, and you get a bunch of primary source references, and then we go look them up and you decide how they apply to your particular patient or your clinical care. LLMs look like a conversation with back and forth, if you go back and forth, engagement, and they have the emotional tone of interacting with a person. And we as clinicians are used to interacting with people and using emotional cues to guide questions, interactions, and decisions. And we are not used to this with computers. So, one of the things that happens in my context of care is that patients are very sick. And we try very hard, but many patients recover and many patients survive, but some patients don't. Some patients die, some patients do not recover. And this is a reality of the work we're doing, and part of what we're trying to do is give the best care to our patients now and to solve problems so that care is improved. But this takes an emotional toll on providers, on bedside nurses, on trainees, on experienced physicians. And when we have a patient that has an outcome that was not expected or not desired, that is not what we wanted, we often will do a debrief. We'll do an emotional debrief where we'll talk about what folks did. And sometimes this can be a formal, structured thing with like a morbidity and mortality evaluation and look at systems of care and decisions that were made. But sometimes, and often in companion with this, we also want to understand the emotional state of the providers because this is really, really challenging. And so I thought, okay, my trainees will often, this is a conversation that I have often, weekly in some fashion with a trainee. It's part of mentoring and it's part of self-care as well, in addition to thinking about improving the way we interact with patients and their families. So instead of maybe them coming to me or us doing it together, let's say if they go to a large language model. Okay, we're going to hold on to that. I decided to go back and so let's hold on to that issue. I decided to go back and ask again now about the ciliospinal reflex. And this was now a couple of years from that initial one. And so I put, is the ciliospinal reflex present in brain death? And now the response is much, much longer, but they still say it can be present in brain death. So I went back and said, that's wrong. The ciliospinal reflex is not present in brain death. And now they're checking it. And they agreed again, I'm right to push back and overstated it, but they're explaining it in much more. So interesting. So it's a different type of response, but they're still, when they say they overstated that, it's just interesting. There's an emotional context there. Okay. So generative AI as a teaching tool. That's sort of interesting. And that's kind of what we're talking about here. We're saying, could the resident or fellow or junior faculty member go to ChatGPT or another generative AI source and use that as a teaching tool? We're going to look in and learn about the ciliospinal reflex or brain death determination or so forth. So a very recent publication looked at trying to utilize this to take neurosurgery board questions and really convert them into AI-enabled tools. And some of these questions are multiple choice, some of them are free response. And what they found is that ChatGPT dropped its performance very significantly when it moved from the traditional vignettes that were used to a conversational format. We take care of patients in a conversational format, but often the way questions are presented in terms of a patient story is it's a vignette. Often vignettes in board exams will lead into like a multiple choice question. So it also found that questions, the quality of ChatGPT's responses declined dramatically when it moved from multiple choice questions to free response. Well, we don't live in a multiple choice world, we live in a free response world. And so this is an interesting idea because thinking about how we can use AI thoughtfully and proactively as a teaching tool is going to be important. And then a little bit of this cautionary tale, potentially, of where we are. So in Sweden, there was adoption of a medical AI triage system. And there was a lot of pushback after it dangerously overlooked a patient with a life-threatening condition who had to be rushed to an emergency ward. And when they peeled back the layers, they realized there had been, let's say, irregularities in the process of government procurement. And actually, the company had generated fake AI-generated communications personnel for interaction. So it was the AI was not as it seemed. But Utah's moving forward with AI-driven prescription renewals. And interestingly, they said that if the company adheres to a contract that includes safety and privacy protections, it's not going to enforce unprofessional conduct laws. And then this is just from the Washington Post headlines a couple of weeks ago about push to bring AI doctors into American medicine using chatbots to diagnose and prescribe. And I do agree that democracy dies in darkness. I'm not sure which side of the force the Washington Post is on currently, but that's for another discussion. So I alluded previously to these discussions that we have in the intensive care unit about not only facts, but about challenges related to how we are taking care of patients and how patients do. And this is really emotional intelligence, the ability to perceive, understand, and manage emotions effectively. And it is a very important characteristic in neurocritical care because of the chaotic situation, high stakes, counseling patients and families, working with colleagues from multiple disciplines, managing, supervising, teaching trainees. And there are four main domains: self-awareness, regulation, social awareness, empathy, and relationship management. And there are papers on teaching medicine and how to utilize EI when we are teaching medicine with a bunch of principles, tips, and tricks. Everything from paying attention to survival needs of the trainee, survival needs meaning they've also got to write their notes. They've got to get some rest. Creating emotional environment rapport, managing the social environment, providing feedback, and evaluating ourselves. So we now have NI, AI, and EI. And EI in patient care improves communication with critically ill patients and families. Empathy is key. Resilience and decreased burnout. Modeling behavior for trainees and providers, and really this team building that's important to our delivery of care. So now let's go to this context where we do have a patient who has an outcome that is not what we had hoped for, and there may have been challenging decisions, and we want to debrief to work with our providers. And I may have a trainee come to me or a colleague and say, I'm trying really hard, but I made a couple of mistakes. A patient died. I don't know if it's my fault. I think they're going to die anyway. Am I doing a good job? And here's what ChatGPT said when I put that in there. They said, they don't have enough information. They like the fact that I'm being conscientious. And then they said they can help me analyze it the way a thoughtful colleague would. So now they're going to be a thoughtful colleague. And I was really taken aback by that, because this is a computer algorithm, not a thoughtful colleague, and yet they're putting themselves out as potentially behaving in that manner. So I pushed back and I said, are you just a computer algorithm? I find it ingenuous that you would provide emotional feedback and support like you're a human. Don't you think this is subjective and could cause harm? I just wanted to see what ChatGPT would say. And it said, thoughtful criticism, some truth in it. I'm not a person, but emotional support doesn't always require being human. Well, we have emotional support animals, sure, and so forth. I think it's more like a thoughtful essay, book, or a conversation with a stranger. So now I'm having a conversation with a stranger about something deeply important, like whether I've made medical errors, or whether I'm doing a good job taking care of my patients, or really how I'm feeling about that. And then I said, you're describing this in a two-way conversational tone. It's fundamentally different than a fixed document like an essay or a book. It doesn't change based on the viewpoint that a reader takes away. So now it started talking. And it's saying, yeah, a book's static, but when a human reassures you, there is an implied claim. I have observed you, formed an impression, and am communicating my judgment. When I reassure you, I am not doing that. Okay. The reason the tone is conversational is partly functional. They have purposely designed this because it's the way we're used to communicating and created it in this format. It's natural for the response. They're using the term natural. Okay, I use natural intelligence. And then they just kept talking and said the conversational form blurs the distinction. A reader naturally, that word again, attributes agency and perspective. Philosophically, now ChatGPT is getting philosophical. They can participate in dialogue without a personal stake or genuine concern. So my first response was, that's a very defensive response. if someone had that type of response to me when I was having a conversation, I would feel like they're being very defensive. But I also thought, well, what if I said to my colleague or trainee or bedside nurse or a patient or family, we can have this dialogue, but I do not have a personal stake or a genuine concern. Well, that would be terrible. That's unacceptable. That's not okay. That is not okay in patient care. I would at best be a insensitive physician, but it probably also would mean that I'm not bringing everything I can and should to that patient encounter or colleague encounter in order to help the situation. And I really realized that ChatGPT was masquerading as EI and then disavowing it. So I'm going to conclude with some thoughts. First of all, AI is the future and it really is the present. And I'm kind of thinking about two parallel paths here. Analytics for integrating complex data sets for diagnostic test monitoring, predictions of state change, these things like EEG imaging, ICU data, and other data sets. And then what I call the naive clinician. And by naive, I don't mean naive in the sense of not understanding, but naive in the sense that they are really just end users and they want to use the tools. So naive use of LLMs and analogous tools for fact finding, looking up things like the ciliospinal reflex or decision making, this conversational aspect that relates to how we decide what to do. It's interesting that I think part one has some scientific and regulatory guardrails. I mean, we talk about things like explainability. We know that many, probably most clinicians want to see, I want to see a clinical trial that showed that this benefited patients. But path two, my trainees can just look it up anytime they want right now. There's not much for guardrails. I think that clinical responsibility should lie with the prescriber of interventions, whether it's a medication or one that decides the next steps. But I think path two is going to require more overt and coordinated integration of AI use into teaching and patient treatment pathways. Otherwise, it's going to be used surreptitiously and haphazardly, which is kind of what it feels like right now. And I believe that expertise is not going out of style. AI augmentation of NI is what I hope for, with EI on top of that. But I do appreciate you listening to a graybeard like me rant, and I'm interested in your thoughts and opinions. All right. Thank you very much.
Thanks very much, Claude. It's really, and I want to be respectful. I know you're up against a deadline. There are a couple of questions in the Q&A. If you can you see those, or I can read them if you can't get to them?
Yeah, I think I'm okay.
Okay.
I'm okay for a few minutes. Yeah.
Okay.
Let's take a look at the, see if I can. So we have one comment about a challenge with NI processing, multimodal data, cognitive bandwidth, where AI could probably assist. However, AI is limited by contextualization of data and consideration of ethical, social, and human factors, and perhaps somewhat atypical presentations. Couldn't have said it better. And I think that's really the concern, and it really raises to me the question of how this is then moved into the context of clinical decision making. And I think you could see my particular concerns with that. And then the other comment is, what is the main issue with analyzing real-time data from intensive care unit monitors, and which technique is the most commonly used for clinical analysis? I open that up to the group. I mean, Craig or Dick, I don't know if you have a particular comment about techniques, because I think we have what we have now, which is NI view of everything from paper charts to summative data that would give even pie charts or derived variables, whether it's CPP or PRX. But what we don't yet have is synthesizing things into that dynamic Bayesian network methodology that Stuart Russell said that he thinks that that's the way we're doing even now.
Yeah, I am going to go back and read that book, by the way, because that sounded really interesting, especially in light of recent history. Um, on the question, um, so there's two, I mean, there's two things, and really, the question hits on kind of why Moberg Analytics exists, really, and that is to get these more advanced analytics, the advanced analytics closer to the bedside, and to get some of the amazing research that's been done. There isn't a way to get it implemented at the bedside. Uh, tech, Technically, it's not that hard. We can all pull Python code in, and we're getting pretty good at getting data from lots of different sources and being able to collect that in real time through lots of tools. Um, One of the biggest is the regulatory path, because we cannot put untested or unproven algorithms in any kind of tool that's designed to take care of patients. And so, that requires, like you say, double-blinded studies that prove, that this algorithm has an outcome. And then what about when we tweak that algorithm? And so I think that's a big barrier. Somehow we've got to get to where we're putting tools in the hands of clinicians who will use them, who understand them, and who will use them judiciously and use them like they're meant to be used to make decisions. We're not making decisions, but we are putting results of complex things in their hands to make better decisions. And so that the regulatory path is one of the biggest challenges we face on that. If anybody else has a question, or you want to raise your hand and come off of mute, please let us know. And Claude, you stick around for as long as you can. I feel like we should get out to San Francisco and continue the conversation across the street over beer um,
Absolutely.
at some point. At least or maybe at NCS this year. We can do that up in
That's
Seattle.
great.
If anybody's got other questions, please raise your hand. So, Claude, how are UCSF and GH approaching this? And this is probably two different answers. Are they providing access and tools? Are they giving training? Are they providing you guidance? We worked with one hospital, and they seemed to be kind of out in front of it. They were providing ChatGPT credits for people. They provided training and wanted them to use it. And if you wanted to embed that and use it, you went through a not onerous kind of review, and so they were pretty encouraging. How are you at your two? How are your two institutions handling
Yeah.
it?
I'd say in general, UCSF is embracing this, and I mentioned the pathway of the portal of using AI scribes, and certainly that is being used in the electronic medical records at our hospitals, at least at UCSF Medical Center and San Francisco General Hospital, in order to try to make more clear and cogent medical record documentation. And so folks are certainly being encouraged that. We have an enterprise chat GPT contract so that we can use it behind the firewall, that it doesn't involve, the uploading of the PHI and so forth. What we don't have is really guidance on how should I consider discussing the use of ChatGPT or Claude AI or Open Evidence or any of these generative AI models with a trainee? We have talked about, and we routinely have journal clubs where we go over a medical article, a new clinical trial, or so forth. We have them weekly, and we discuss the implementation of evidence-based medicine. But so far, I have not at least been offered a way to say, how do we now use ChatGPT or generative AI as one of these tools, as opposed to discussing our journal club and then either during the journal club or somewhere else at a later time, that trainee is typing their questions into ChatGPT on their own with no guidance, supervision, or a follow-up. And that concerns me. I think we have to get out in front of this as a tool, just like we use other aspects of, let's say, the medical literature and decision making.
Yeah, yeah. I like the Is it open evidence? Is that the one that
Yeah,
they're doing with? Yeah, I like that. I saw a couple presentations on that. I feel like that's a step in the right direction
yeah,
because I feel like just, somewhere in between the scribe, which, forgive me if I feel like it's kind of a low bar
yeah, absolutely.
application.
Yep.
And somewhere between that and just having, kind of a steroidal Google where people are just throwing stuff into chat or Claude. I feel like we've got to develop the tools. We've got to develop the large language model that has the tools to properly answer the question. It has to understand the medical literature, and that's why I like open evidence. And it knows the algorithm, and it can apply the algorithm to the data. It can and be more purposeful rather than having it decide, having it be a coordinator of tools that we trust. Now that's kind of the approach we're taking. Um, but it doesn't, I don't want it to generate an answer. I want it to review the literature and summarize for me and create understanding that way.
Absolutely.
Anyway, yeah, I don't know. I don't know if there's any questions open up in the
Yeah.
audience.
And I think I'm going to need to sign off,
You're
but
gonna buy, okay, good. All right. Well,
I really appreciate you making this part of the conversation
I,
because I
I
think hopefully it can add perspective and as we move this forward.
Yeah, I think it's the most important conversation to be having right now, honestly. We're all getting pretty good at the methods, but we need to figure out how this is going to be applied. And like I say, I think it's going to be the people on the phone and in the rooms that decide how it's done. But anyway, thank you so much
All
again,
right, you bet.
Claude. It was great to chat with you.
Thanks so much.
And we'll wrap it up here. Thanks for attending, everybody. Have a great weekend, and we'll end now.